factors. I'll look at the treatment of peri-implantitis and how I treat it. And my treatment, I can tell you, is very simple. Nothing fancy with my treatment. I keep it very simple. And also, I'll look at some strategies to minimize the risk in periodontitis patients, because we know these are the patients who are most at risk. So the first thing that we have to remember is that when someone develops peri-implantitis, it can progress very rapidly. It behaves like an aggressive periodontitis. So you see an example here of a patient. The implant was placed in April 2011. November 2011, everything's looking fine. And 6 years later, we start to see some marginal bone loss. The dental hygienist has a look at it, but doesn't say anything to me. Oh, it doesn't look quite right. Okay, and then suddenly, from February to October 2017, it's rapidly progressing. Okay, so the one message I want to give to everybody is that with peri-implantitis, don't look at it and go, oh, maybe we'll check next time and see how it looks. You need to intervene and you need to treat it, because it behaves very, very differently to other types of infections. It can progress very rapidly. And especially if you're dealing with implants that have a micro-rough surface, it can go quickly. And then if you have implants with a porous surface and have very rough surfaces, then it can accelerate. So don't watch and wait. It requires prompt treatment. So if we look at the risk factors for peri-implantitis, we can broadly look at 2 risk factors. On the one hand, we have patient-related risk factors, and then on the other hand, I'll put down dentist risk factors. That means us making some clinical decisions that maybe increase the risk. Okay, and I'll talk a little bit about the model of disease versus the model of a complication. So patient risk factors, we know that periodontitis and peri-implantitis are essentially not too different from each other in terms of the etiology, pathogenesis, and the risk assessment. We've known this now for more than 20 years. And we know what makes people more susceptible to peri-implantitis. The difference being that because you have a rough surface and a deep pocket, which is anaerobic, the disease can progress incredibly quickly and rapidly. So what are the patient risk factors? I think the number one risk factor is oral hygiene, or lack of oral hygiene. So there is substantial evidence showing that poor oral hygiene is associated with peri-implant disease and marginal bone loss. So the odds ratio for this is 14.3. So what does this mean? The odds ratio is, what are the odds of someone developing a condition or a disease that has the risk factor compared to what the odds of another person getting the disease without the risk factor. So the disease is peri-implantitis, the factor is oral hygiene. And if the odds ratio is 1, it means they are equivalent. They have the same risk. If the odds ratio is 2, it means there's a 100% greater risk. You see here a 14.3%. That's 1,300% greater chance of developing peri-implantitis with poor oral hygiene. So I'll repeat that. Odds ratio 14.3 means the odds are 1,330 times higher than someone who doesn't clean their teeth compared to someone who cleans their teeth. So the odds are very high. Bottom line, if your patient is not compliant, whether they're a periodontal patient or not a periodontal patient, if they show no willingness to keep their own teeth clean, don't place implants on them, because they are a recipe for peri-implantitis. You have to have your patients understand this and cooperate this. Periodontitis, we know, is a risk factor. And if you have patients with residual pockets of 6 millimeters or more, with inflammation and bleeding after probing, they have a much higher risk of developing peri-implantitis. So these can be patients who you are treating, who have been treated but still have residual pockets. In other words, they still have active disease. So these patients are not good patients to have implants placed. And if you do choose to place implants on these individuals, you have to ensure that they're highly compliant, meaning they will come back for for maintenance and for you or your hygienist to review the patients on a regular basis. So beware that residual untreated disease is a significant risk factor. Cigarette smoking. This used to be thought of as a very high risk, but more recent studies have lowered the risk somewhat. So the odds ratio is 1.7, meaning there's 70% greater odds or greater chance that a smoker will develop periodontitis compared to a non-smoker. I mean, it's still a significant risk, still 70% greater, but it's not as high as what was thought originally. Then we have the combination of periodontitis and smoking. So this combination exponentially increases the hazard or the risk of the patient developing periodontitis. So this is this concept of multiple risk factors. So now you have a patient who smokes, doesn't clean their teeth, has pockets greater than 6 millimeters remaining. So each of these has a risk. Now you have multiple risks. It's very difficult to quantify what the multiple risks are. Some studies like this show that combination increases the overall risk. And then if there are periodontal patients, they must be in a supportive maintenance program. So here is a study by Costa in 2012. They took partially edentulous patients with periodontal mucositis. Right? Regular supportive maintenance was in 39 patients, and those without maintenance had 41 patients. And they looked at them 5 years later. Those in regular supportive maintenance had an incidence of periodontitis of 18%. Whereas those without maintenance, from the mucositis, they went on to develop periodontitis of 43.9%. So the data is so strong and so overwhelming for the need for supportive maintenance. So now I ask the question once again. Patient comes to see you for the first time with periodontal disease. You provide them periodontal treatment, everything goes fine, and you say, right, you can go on and do implants. How do you know if the patient will come back for maintenance? Can you predict this? How many of your patients come back for their regular checkups after you finish treatment? What proportion? If you do an analysis in your practice, you'll see actually it's quite low. A lot of people do not come back after the treatment. They forget their excuses and other reasons. So particularly with periodontal patients, you can only tell if they're going to be a compliant patient if you have treated them for a period of time. You cannot tell after one visit, after 2 visits, after 6 months. Because basically I don't trust my patients to come back. They need to prove to me that they're going to be compliant before I will think about dental implants for them. And of course we spoke about that this morning. The other site-related factors in the periodontal patient, lack of bone, lack of keratinized tissue, and so on. The evidence now is overwhelming for the need for good tissue, soft tissue thickness, and good soft tissue, and good zone of keratinized tissue for the patients. So here is a summary of patient-related risk factors with the odds ratios for each of them. Poor oral hygiene, the highest, 14.3. So remember, it's 1,330% higher odds. Tobacco smoking, 1.7. History of treated periodontitis. Treated, under control. You still have odds of about 3 to 4 odds ratio. Residual pockets, the odds ratio is 5. Lack of maintenance, almost 6. History of periodontitis and lack of maintenance shoots up to 11. And then the diabetic patient, 2.5. So now I have a patient who smokes, doesn't clean their teeth, has gum disease, pockets, residual pockets, doesn't want to come back for maintenance, and has diabetes. So what do you think the chances of that patient developing periodontitis? And it's almost guaranteed. At some point over the next 3 to 5 to 8 years after you place the implant. So now I ask the next question. Who is at fault? Is it the patient because they have all these risk factors? Or is it because of you as the dentist who decides to put the implant into that patient's mouth? So we have to sometimes ask ourselves some very hard, tough questions about our approach to managing these patients and to avoid these types of complications. So I would like to just stop a little bit and maybe look at things in a slightly more philosophical way. Peri-implantitis only exists because there's a dental implant. No implant, no peri-implantitis. In other words, peri-implantitis is a man-made disease. Yes, and for a long time we have treated this as a disease. It's not natural. It's not natural because we have a piece of titanium sticking out of the patient's jaws. Okay, and if you look into the orthopedic literature, they have what is known as periprosthetic infections and complications. And they talk about things like aseptic loosening. So the implant, the hip joint has started to move in the bone. It's lost its integration. We call it overload. Right? Periprosthetic fractures. So they call it a fracture, we also call it a fracture. Then there's joint infection. They call it infection, we give it the name of a disease, peri-implantitis. So in dentistry, we treat it like a disease. In orthopedics, it's an infection. It's a complication. Right? And you just look at this sort of a review article like this. You can pull up any review article on periprosthetic infections. And not once is it referred to as a disease. It's not a disease because it's an infection on a joint. Why is it in dentistry we call it a disease? I don't know. Maybe it's because all the periodontists got involved 20 years ago and decided we're going to call this a disease and treat it like a disease. Now, the one good thing about treating it like a disease is that we have made so much progress in understanding the patient-related risk factors because we are treating it like a disease. So it's like diabetes. Diabetes is a disease. So we look at risk factors, weight, exercise, genetic predisposition, and so on. Yeah. So that's where the approach is very different. It's like a physician. A little bit closer to the mouth. These are bone-anchored hearing aids placed into the skull. And a paper on complications of bone-anchored hearing aids. Proper patient selection, meticulous surgical technique, and good hygiene around the implants is the most critical aspect in minimizing complication. Does it sound familiar? So I could just change this to dental implants. We want exactly the same thing. Proper patient selection, meticulous surgical technique, and hygiene around the implants. Exactly the same. But not once do we refer to this as a disease. Never refer to it as a disease. And yet we refer to it as a disease. So we have what I call the disease model of an infection versus orthopedics, which is the complication model. Now the problem with the disease model is we attribute the etiology mainly to the patient. That's the patient's fault. It's a disease. It's the patient's fault. Remember, no implants, no disease. It's man-made. The complication model attributes the etiology both to the patient and the clinician. Because if I'm an orthopedic surgeon, I can have an error in the placement of the hip. I can have a complication at the time, right? So we have there is responsibility taken by the clinicians involved in the treatment. So while I think it's been fantastic that we looked at peri-implantitis as a disease, I think what it's done is it's made us as dentists forget that it's a complication and that we actually have a lot to do with the development of peri-implantitis in our patients, because we are in the driver's seat. I'll share with you this study from Professor Danny Bruza, published in 2012. This is a 10-year paper on tissue level, and it's relevant for the next lecture. And Dr. Lam spoke about this, that the tissue level design is a wonderful design. And this is tissue level implants with an SLA surface. 10-year prospective study. Retrospective study. 303 patients with 511 implants partially edentulous reconstructions, not full arch, conservative surgical approach. So the conservative surgical approach means no immediate implants, and or it's early implant placement, or if it heals site, not enough bone, graft first. So this is what we call a conservative surgical approach, very low risk. Make sure the bone is healthy before the implants are placed. So Danny, Professor Boozer, showed a 10-year survival rate of 98.8% and a 10-year success rate of 97%. Right, so this is the absence of complications. So over 10 years, only 3%, 3 out of 100 implants developed a complication. Incredibly low. I wish in my practice I would be as low as that. Yeah. But I do immediate implants. Sometimes we do a little bit of risky procedures, we increase our chances of failure. So look at the peri-implantitis. Surviving implants, of the surviving implants, 0.4, 2 out of all those patients had peri-implantitis at the time of examination. And 7 had a history of peri-implantitis in the 10 years before that. Overall, the prevalence of peri-implantitis is 2.8%. That's very low to what is reported in the literature. And these are not patients in maintenance. These are patients who will be treated and they go back to the general practitioners and they receive more dental care. The difference is the low-risk surgical approach to make sure that the foundation for the implant is sound, good bone and good soft tissue. So no immediate implants, GDR done to reconstruct the bone, and when necessary, stage bone grafting. So sometimes, as I said, more treatment is required to have less risk and higher predictability. I think we need to take lessons from the burn group, the all surgical department in the burn group run by Danny Bruiser, to think about how we approach surgery for our patients, and particularly those patients with the risk of peri-implantitis. So I published this chapter in the 3rd ITR treatment guide with Danny Bruiser. He was doing a sabbatical in Melbourne for 6 months, and we sat down and we wrote treatment guide number 3 while he was on sabbatical. We actually worked through Christmas time. He's crazy hardworking. I don't think I could have done it. If he stayed for longer than 6 months, I would have gone crazy, because he's such a hardworking individual. But we said there are all these multiple risk factors for complications. You have the clinician, you have the patient, you have the biomaterial, you have the treatment approach. So all these things factor into the complication. But guess what? The clinician assesses the patient to see whether they're a suitable patient or not. The clinician chooses the biomaterials, what implant system, what grafting materials to use. The clinician recommends the treatment approach. I never had a patient come to see me and say, doctor, I lost my upper molar, and I want a type 3 treatment with the transcrestal sinus flow graft for you to replace this tooth with implant. Never. The patients never specify the treatment because they don't know. They trust you to provide the right recommendations. So as dentists, we are in what we say in English, we are in the driver's seat. We are driving the bus. And we make all the decisions about which direction we go, which patients to accept for treatment. And so if you take the complication model rather than the disease model, you can see that the clinician has a lot to do with the decision making and has a lot to do with the etiology of complications when they arise. So now let's look at clinician-related risk factors. So there's periodontal patients. So periodontal patient is a patient risk factor. But if you put the implant into the patient who's not got controlled periodontitis, and you have made the decision, now it becomes a clinician risk factor because you've made an incorrect decision. So this patient was referred to me, had implant work done overseas, no maintenance, no treatment of the gum disease, and we wonder why his mandibular implants on both sides had failed. So we've taken them all out, provided treatment, and we've done the reconstruction. It took several years to get to that stage. Placing implants into narrow ridges. So if you put an implant into a narrow ridge, it develops inflammation, aseptic necrosis. We spoke about that this morning. Whose fault? The narrow bone is a patient risk factor, yes. But me putting the implant in. This is my case, I put this implant in. That was my decision, right, to try and save the patient bone graft. It didn't work. Now we have a susceptible implant sitting there. Fortunately, it's still being maintained. Yeah, but it's a clinician-related risk factor if you choose to proceed with the treatment. Peri-implantitis. Have a look at these cases of peri-implantitis. And what do you see? These are all crater defects, almost 360 degrees around the implant. Yeah. So these are implants that were probably placed into good bone. And then the patients developed peri-implantitis, so you get the circumferential bones. Okay, so all right, maybe this is really peri-implantitis, except when you see this. You see the cement tag? And the cement tag, where is the cement on? It's on the implant surface. If the implant was in bone to start with, how does the cement get onto the implant surface? The bone was never there, right? It was never there when the prosthesis was cemented. So that probably went into an extraction socket, or an early healing socket with a site where there was no bone. So sometimes we say, it's peri-implantitis. This can be iatrogenic as well. But let's say all of these cases, all the implants were in perfect bone, and therefore we could argue that this is most likely peri-implantitis. Have a look at these cases. These cases are all dehiscence defects with loss of the buccal bone, loss of the lingual bone. These are implants placed into narrow ridges. Implants placed into narrow ridges so that when they develop bone loss and then they develop a biofilm infection, it spreads around the implant, but you get this through and through defect. Buccal bone loss, lingual bone loss, buccal bone loss, palatal bone loss. Yes, this is peri-implantitis, but these are implants placed into narrow regions. So next time you have a case of peri-implantitis, either a patient you treated yourself or that's referred to you, have a very close look at the bone morphology and try to think, was this really peri-implantitis, or was it a failure of the treatment that was provided to the patient resulting in bone loss and now has ended up with peri-implant infection? Because I know we talk about there's lots of peri-implantitis, people say there's an epidemic, but most of it, I firmly believe, and I don't have evidence for this, but I think the majority of these implant complications have an iatrogenic component. In other words, a dental-related issue with wrong decisions being made for the implants to be placed. Here is another clinician risk factor. Implant placed into extraction sockets. We spoke about that this morning, and we spoke about the fact that when an implant is placed into the socket, you're expecting the bone to heal. So the first question you have to ask yourself is, when I take out a tooth, and I come back 8 to 10 weeks later, do I always find bone filling in the socket? Or do I sometimes find a residual defect? Or I sometimes find granulation tissue that's still there? Sometimes it doesn't heal, sometimes it heals. We don't know, this is so variable. So this is a patient, I placed this implant as an immediate implant, developed infection, I go back in, it looks like a fresh extraction socket. This is the site where the regeneration failed to work. So I did the grafting, but it just did not work. And so we have a residual peri-implant defect. It's almost exactly the same as the day the implant went in. Here's another case referred to me. Please treat peri-implantitis. So I open a flat, cemented crown. You can see the cement. You can also see a non-healed extraction socket. Okay? So we expect that when we place an implant into an extraction socket, it will fill with bone. It doesn't always fill with bone. So we have to go back to the literature. Now these are older studies now. One of them is my study in 2007. And the reason we don't have too many of these studies I mentioned was it's very rare now to be able to do re-entries. It's very difficult to get ethics approval now for re-entry procedures. All these sites are grafted. Internal grafting of the extraction sockets. And you see in the blue, complete fill. And you see in the orange, incomplete fill. How many percentage of the sites with incomplete fill? So the incomplete fill ranged from 10% in the David Gelb study down to 80% incomplete fill in the Wang study, Hongmei Wang study, with one of his postgraduate students in 2007. Wow. So what's happening? If we put implants in and we graft and we don't get filled, then we've got exposed implant surface in a high proportion of cases. And then when we get peri-implantitis 5 years later, we go, oh, I wonder why that happened. Oh my goodness, peri-implantitis. But maybe it was because the conditions were not right, and we ended up with bone loss. And then of course cement. So everybody says, do not cement your implants now because of the risk of peri-implantitis. And Tom Wilson published a paper very early on alerting us to that. So here we go, excess cement. But where is the cement? It's on the rough surface of the implant. Is that cement, or is it because of the failure of the treatment? And then an uncleanable prosthesis. If the patient cannot clean, you cannot clean, nobody can clean it, we're going to run the risk of developing problems. And then we used to ask our patients to use superfloss to clean underneath. It resulted in a lot of floss being caught, tags, and developed peri-implant infection. So these are all things that are iatrogenic. Okay, so how do we treat this? I have a very simple approach to treatment of peri-implantitis. Peri-implantitis is a biofilm contamination on the implant surface. And when you have a biofilm contamination on the implant surface, to treat the infection, you have to remove the biofilm. Now, removal of the biofilm requires access to the affected surface. Sometimes we can do it closed, sometimes we have to open the flap, sometimes we have to take off the prosthesis, but you need access. And then, how easy it is to clean depends upon the implant surface itself. Whether it's a very rough surface, porous, or whether it's a micro-rough surface like an SLA. So different implant surfaces have different approaches to that. So the principle is simple. Disrupt and disperse the biofilm. And this requires mechanical disruption of some description, whether it's physical disruption with your hands, ultrasonics, air spray, or air powder sprays, or whatever, or titanium brushes. It doesn't matter. The main thing is that you have to disperse the biofilm, and you bring then the bacterial load down to a level that's low enough for then the body, the patient's natural immune system can then take over and decontaminate and remove the rest of the bacteria. So that's what you're after. So reduce the microbiological load. So let's look at a case of mucositis. So you see here a patient whose prosthesis has been in place for a couple of years, comes in slightly increased in probing pocket, bleeding after probing, and look carefully at the slight reduction in the radiodensity of the bone. It's not bone loss, but it's a reduction in bone density compared to previous radiographs. And that's because there is inflammation, and the inflammation is causing the bone mineral to be leached out. This is the start of peri-implantitis if you don't catch it. So what we do is we debride the sulcular region with floss, with titanium curettes, with erythritol air polishing devices, whatever you can and whatever works for you to clean the biofilm. In a closed way, no open flap, because it's still quite shallow. Then provide the patient with proper education how to clean the area. You can sometimes use topical disinfectants like chlorhexidine gel. Right, so here's what we use, these mini titanium curettes around the implants. And here is some time later. Right, so the infection has resolved, and you can see the return in the radiodensity. So the x-rays will tell you if you've been successful. You'll see an increase in radiodensity around the implant. Okay, so it's successful treatment. And he's still in maintenance right up to today. Comes in once a year only now, because he's very good on hygiene to do the checkup. I think that one of the big advances in monitoring and maintenance has been these powder compressed air water jets. This is the EMS Airflow Plus. Because these, if directed carefully around the implant reconstruction, can go down into the pocket several millimeters. And it avoids having to use metallic instruments to try and clean around some very difficult reconstructions. So we bought one. This is great. Then the hygienist wanted one. And then we started, there's myself and my 2 other partners. And then we have 3 hygienists. Everybody's fighting for it. In the end, we have 6 now. Because we're using them all the time. All the time, not just for our implant patients, but patients who have extensive crown and bridge work, cleaning with gentle powder spray around crown margins. It's a perfect way to clean around fillings, cervical fillings around dental implants, and fixed tooth prosthesis. So this I recommend, strongly recommend this to you. So that was mucositis. So peri-implantitis, so it's depending upon the extent of the bone loss, if you choose to treat it or not. And that's a very subjective decision. So what are the principles? Access for removal of biofilm. That's the only thing you have to think about. And if you can get access without opening a flap, fine. If you cannot, you have to open a flap, or you might have to remove the prosthesis. Here we have a tooth to implant prosthesis, cemented. So there's no way I can take the prosthesis out. We have to treat this with the prosthesis position. So the treatment of early peri-implantitis is oral hygiene education. If necessary, modify the prosthesis to make it more clinical. Local debridement under local anesthesia, titanium curettes with air powder cleaning. Sometimes we think about systemic antibiotics. I only consider that if I see suppuration. And then topical chlorhexidine gels as a follow-up to manage this. And most mild peri-implantitis can be managed. With moderately advanced peri-implantitis, then I think you need surgical access, because just getting to the surface is very difficult, especially around the threads and so on. And if it's very advanced, then implant removal is probably the way to go. Now, this was a paper that was published in 2016 by Lisa Heiss-Mayfield. I think Lisa's probably all known to you. She's periodontist, was in Europe for many years, now she's back in Perth. She's also the editor-in-chief of Clinical Oral Implants Research. A very powerful position, because she says what can be published and what cannot be published. Yeah? So this was a multi-center study. I contributed a couple of patients to this multi-center study, 36 implants in 24 patients, all treated with open flap debridement, adjunctive systemic antibiotics, combination amoxicillin and trimethazole. Then importantly, daily chlorhexidine for 4 weeks, and then supportive therapy for the first 12 months on a 3-monthly basis. And then the patients went back to the referring practitioners and came back 5 years later. So the patient-based data of the 24 patients, 4 of these patients in the gray were lost to follow-up, so they didn't come back, so they left 20 patients. 15 of the patients, or 63% had success, no recurrence in the disease. So almost 2/3 of the patients had no recurrent peri-implantitis. I mean, that's a good news story, isn't it? 5 years, no recurrence. Of course, there were some that had recurrence in the disease. And if we look at this on an implant basis, there were 36 implants in these 24 patients. Of course, 4 patients didn't come back for follow-up, meaning that equated to 8 implants that didn't come back, so leaving behind the remaining implants. So you can see on an implant basis, there was success in 19 of these implants, so 53%. So when I see a patient with peri-implantitis that's not advanced, in early to moderately advanced peri-implantitis, I say to them, if I treat you, you have about a 50% chance of, as long as you do all the right things, a 50% chance of retaining this implant and without recurrence over a 3 to 5 year period. I try and be a bit conservative. If you have a recurrence in the disease, you then have to make a big decision. Do you keep retreating it, or do you make a decision, it's time to take the implant out? So I will attempt treatment once, but I generally don't like surgical treatment second time, third time, fourth time. It's pointless if it's going to become continuously reinfected. So what does the surgery involve? So this is August 2007. This is a patient that I placed an immediate implant on. All right, so there's the periapical radiograph, and there's the periodontal probe into the pocket, going all the way up to the apex. Yeah, so there was a non-healing of the extraction socket. So this is one of these immediate implants placed without any grafting, because the jumping gap was supposed to fill with bone.